in which I will speak about how to approach to a common neonatal disorder, applying the pathophysiology and what we know from the first and second part. So at first we have to know that the ventilatory support in neonate, most of the evidence came from observational study and from understanding of the physiological principle, plus expert opinion, and very few randomized trials are known. So let's speak now about respiratory distress syndrome, and here it will be combined with the pneumonia because both of them have relatively homogeneous lung disease and they can coexist, and the clinical picture and the radiological sometimes cannot be differentiated from each other. And both of them, if early treated with non-invasive support, it will maintain the adequate lung inflation and avoid the surfactant inactivation, and in most of cases the baby will not go for mechanical ventilation and intubation. But if left without adequate support, maybe pulmonary hypertension will occur and the progressive surfactant inactivation, and at the end baby will be intubated and the mechanical ventilation and may stay longer time than if early treated or may have some complication like pneumothorax. So what are the pathophysiology? As we said, it is relatively homogeneous lung disorder where there is relative surfactant deficiency or inhibition and the lead to atelectasis. So the lung are prone to atelectasis and the compliance will become poor with regional lung difference according to the gravity. So our key of management here is to recruit the alveoli and then to maintain recruitment of the alveoli and to maintain the end expiratory lung volume. So what are the supporting structure which we choose? It is only synchronized and must be synchronized, and SIBV or AC or PTV is better than SIMV because it is fully supportive for the baby. The baby who is sick at birth or small and his spontaneous respiratory effort is poor will be supported. But if in SIMV there is part of the rate of breathing will be depending on the baby, and it is better to protect the baby against the high pressure or low tidal volume or change in the tidal volume from cycle to cycle to start volume guarantee. So starting volume guarantee early is better, and then go to put your setting related to the PEEP rate, inspector time, and the VG. So for the PEEP, there is no universal PEEP for all patients. It depends on a lot of factors: how much severity, how much atelectasis, what is the size of the baby, how much prematurity. But initial level of 6 is reasonable at the starting point. Then you can adjust over the time and according to the finding in the X-ray or the graphic. And from time to time the pathophysiology will change and you can adjust. So take care that very low PEEP inappropriate and you will cause atelectic trauma, and the high PEEP or optimal PEEP at the start may become excessive at certain time, like when the compliance improved as the baby improve, or the compliance improve after surfactant, and then you will be faced by the overdistension, incomplete exhalation and the hypercapnia, or affecting the venous return, and maybe as a complication of overdistension go to pneumothorax. The tidal volume start at 5 ml per kg and then adjust according to your clinical assessment, the graphic measurement of the ventilator. Inspector time. What do you suspect here in the inspirator time? According to the 3-time constant, you can adjust your inspirator time, putting the fact that in normal, the time constant for inspiration is less than the time constant for expiration, 1 to 2 or 1 to 3, and in respiratory distress syndrome, generally this time constant become more short and affect both the inspiratory and the expiratory. But if you go to the expiratory time, you will find that the elasticity, which is high, make the empty of air on expiration is easily than filling the alveoli during inspiration. So take care when you are putting the inspirator time, don't make it so short. Make it and adjust it to be enough to complete the inspiratory flow before the ventilator cycle off and the start of expiration. But at the same time, don't make it so long to avoid the inspiratory hold and its side effects. And then you can adjust it based on the flow curve on the graphic. And you take care also that the time constant is affected by the size of the baby. So a preterm baby is not like a term baby. And based on this fact, there is a lot of rules will be given later on in other diseases. What about the rate? So choose the rate which you can give enough inspiratory time without affecting the expiratory time. So use a low rate like 40 per minute. Don't go to 60 from the start. Start by 40. High frequency ventilation in pneumonia or respiratory distress syndrome. The role is to achieve initial lung volume recruitment and to maintain the optimal lung inflation with the lowest possible MAP. Most of our unit, including our unit, who are using high frequency if we have failed the conventional mechanical ventilation, but others can use from the start in some babies. So when you use high frequency and shifting from conventional to high frequency, you have to be sure that you fail to maintain the optimal ventilation by the conventional mechanical ventilation. You optimize your ventilation and then fail, then you are going to the high frequency ventilation. And when going to high frequency ventilation, we have, as we said, ways to recruit the alveoli and then to maintain this recruitment. So the process of lung recruitment consists of 3 steps. This is the first steps where you start your high frequency by a map which equal or 1 or 2 plus the map which was on the conventional mechanical ventilation, and then start to increase in a stepwise up every step in 2-3 minutes gradually by 1 or 2 in the map, looking to the oxygenation, oxysaturation, and if you have transcutaneous CO2, looking to the CO2. And the increase in stepwise until what's called the opening pressure, where oxygenation improved and no longer improvement if you increase the map again. So this is the first step. So you reach, for example, 18 or 20, and you found that here, if you give more, there is no more improvement in the oxygenation. So subsequent stepwise reduction to reach the closing pressure, at which when you reach less than that level, for example 12, if you come less than 12, at this point oxygenation will start to deteriorate. So now you know the maximum pressure after which no more oxygenation will get, and the lower pressure under which no oxygenation and start desaturation occur. So where you will put your baby? In a point between these two. So take around 2 above the lower pressure like if you reach till 12, make it 14. But take care, you have to recruit the alveoli first. So you have to go up again to recruit the alveoli, then you can come more quickly to that level. And in the first step, initial step, when you reach up, and if, for example, you were on 100% oxygen, start to wean before you go down till 60. Then you come down. So, initial step of going up to know where is your opening pressure, then stepwise reduction till you know where is the closing pressure, then recruit the alveoli, and then go down again to just above the closing pressure by 2. And in between this, you had reached by the oxygen from 100 till 60 or less. So this recruitment of the alveoli and maintaining optimal lung inflation by the lowest most possible MAP. By this process, you place the lung on the deflation limb of the pressure volume loop with optimal gas exchange. So it will be here or here with minimal pressure and the hemodynamic consequence. So you avoid the area of hyperexpansion and you are avoiding the area of atelectasis, and you are in the safe area with good ventilation. So in high frequency setting, what is the setting you'll use? The frequency in term infant we are using 10, in preterm we are using 15, and this is why look at the, if you consider this is the 10 frequency, this is little more frequency 15, for example. So this area under is tidal volume, this area under is the tidal volume. Okay, look here at this area, the time, the less the frequency, the more the time, inspiratory time and expiratory time here. The less, sorry, here, the more the frequency, the less the time. The less the frequency, the more the time. So for a preterm who has normally the respiratory rate is high because the inspiratory time is less, better to start by 15. While in term baby you can start by 10. This is with the physiological basis, number 1. Number 2, related also to your disease. The amplitude will be adjusted just to achieve adequate chest volume. This is a rule. And as lung compliance change by the time, the mean airway pressure must be adjusted. So which mean airway pressure we can use? We can start by the mean airway pressure, which equal to that started by or was on during the conventional mechanical ventilation plus 2. And when CO2 decrease, it is preferred to reduce the amplitude before reducing the frequency, because every small change in the frequency will affect highly the tidal volume. So better to start go down by the amplitude or go up by the amplitude in relation to the CO2 without changing your frequency. This is the second about meconium aspiration. So about meconium aspiration syndrome, most infant born through meconium stent fluid are doing well, and now currently we are not intubating the baby for meconium aspiration before initiation of breathing. We are going by the NRB as any baby. So meconium aspiration is relatively infrequent, but its effect will show you a very bad effect on the baby because of the pathophysiology which we'll mention now. So the pathophysiology is complex and it involves the surfactant inactivation, inflammation from the meconium, and there is a variable obstructive component with air trapping and atelectasis from the ball and valve mechanism. Air trapped impair ventilation and also may impair the oxygenation by local pulmonary vasoconstriction and by the direct compression over the microvasculature of the lung. There is long time constant because of the air trapping, so it needs more time to empty the air during the expiration, must be considered. And in some cases there is element of pulmonary hypertension due to the inflammation itself or the perinatal hypoxia, which is a possible cause for the passing of meconium. So now we have 3 pathophysiological change and we have prolonged time constant. So the clinical presentation may be one of two. Number one, which with homogeneous lung pathophysiology, in which the main pathophysiology is the surfactant inactivation and inflammation. It looks like the pneumonia, like the respiratory distress syndrome, and it's homogeneous. While the other one heterogeneous, where there is surfactant inactivation and inflammation plus more air trapping and atelectasis, which is number 3. So you have 2 pictures of meconium. So you will have 2 strategies of ventilation, and putting in your mind time constant is high because time constant will give you the inspiratory time, the rate, and expiratory time. So the goal of respiratory support will be optimize lung inflation by application of distending airway pressure to recruit the alveoli, which have atelectasis, and at the same time you have to minimize the overinflation of the more compliant region and minimize air trapping. And during that you have to put in your consideration, as we said, the time constant for adequate exhalation and for better inflation during inspiration without over distension and without possibility of air leak syndrome when pneumothorax. To give Cervanta during treatment of meconium, it is controversy, but acquired surfactant dysfunction will occur from the meconium, and you may require to give oxygenous surfactant. Some are giving surfactant by the usual way, but slowly. Other giving like with saline wash, but still it's controversy. So how to approach ventilation of meconium aspiration syndrome? In mild or moderate cases may require no mechanical ventilation, and some cases are very mild that it need only nasal cannula. Some cases need CPAP, and a lot of us are afraid to give CPAP and PEEP during meconium aspiration because there may be a pneumothorax, but CPAP is important. The distending pressure given by applying this PEEP lead to the treatment of surfactant dysfunction and stimulate the new surfactant production. And at the same time, the CPAP makes splitting and stabilization of the airway, especially during expiration. So it will make adequate exhalation and prevent more air trapping and airway obstruction. So nasal cannula or CPAP according to the clinical picture of the baby. And in more sick baby, you will go for mechanical ventilation, either by conventional or by high frequency. And the recent study now shows that conventional is preferred than high frequency in cases of meconium aspiration syndrome. So the need of ventilation here, the strategy must be individualized according to the case, with frequent assessing the baby for the predominant pathophysiology from time to time. The best way is to give SIMV plus pressure support. SIMV, so you can control the rate and the inspiratory time, and BSV to help the baby during the part which he will drive by his spontaneous effort, so to control the rate and to have proper inspiratory time and to avoid auto beep. SIMV plus BSV is preferred, and from the start you have to start by volume guarantee, because larger volume will be needed as the pathophysiology include increase in the dead space. So you can start by 5 and then increase according to the case. So what are the setting in conventional mechanical ventilation? As we said, depend on the predominant pathophysiology. So we have two pictures according to the predominant pathophysiology, but we have in both of them fixed time constant, which is the time constant in both is long. So when the predominant pathology is the alveolar disease, where there is surfactant deficiency or inactivation plus inflammation, so the picture resembles pneumonia or respiratory distress, there is low tidal volume. What is the beep which will be used? Must be enough beep to make recruitment. So should be higher, start by 6 and increase or decrease as needed. For the inspiratory time, must also be adequate to achieve complete tidal volume. But take care here that the baby may need also time to empty during expiration. So the rate must be adjusted, avoid high rate to avoid the auto beep. The second type, when the predominant pathology is the air trapping. So we have area of air trapping and the area of atelectasis. So the beep here should be limited to 5, maximum 6, to avoid more over trapping, to avoid trauma, barotrauma or volume trauma, but at the same time must be enough to stabilize the alveoli and the airway during expiration, so emptying and avoid more air trapping. And the expiratory time must be enough to minimize this gas trapping, as the time constant, as we said, is long. And the rate should be lower to maintain good expiratory time and enough inspiratory time for inflation. So in meconium syndrome, if now the baby has predominantly picture of respiratory distress syndrome, surfactant inactivation plus inflammation, so the beep must be more than if the predominant picture there is air trapping, and the inspiratory time in both cases must be enough. But in case of air trapping, we will make it less to give more expiratory time for emptying of the air from the alveoli and to avoid the auto beep. And in both cases, better to start by lower rate, like 40. This point is very important, that some, because of they are afraid about the air trapping or they afraid from the name of meconium aspiration by itself, they make use of low beep, very low beep. And this is not physiological and not sound, as we said, because it will make more trapping of air and it will make the recruitment of the alveoli very difficult, which is compressed already. But with good beep, air trapping may be relieved by stabilization of the airway diameter during expiration and prevent airway collapse by the pole and valve effect. So you can adjust your beep and make use of your X-ray and your graphic to avoid the auto beep and to avoid very short inspiratory time. This is very important. What about high frequency? High frequency when the baby become more sick, so high frequency oscillatory ventilation will be used. Some are using the jet ventilation, and you can use this as per the pathophysiology. So the pathophysiology, we have long time constant. So if you have long time constant, so use lower rate. With high frequency, safe and effective. Why low rates? As we said before, when you have low rate, you have more inspiratory and more expiratory time, as we showed before. For infant with significant air trapping, here the mean airway pressure should be similar to that on conventional mechanical ventilation. Because now you are afraid from the overdistension, you are afraid from air leak syndrome. The amplitude, as a general rule, to make it adequate to the chest vibration, you can adjust it by starting by 2 times or 2.5 times of your map. If you are using map of 13, start by using 26 to 28 and then increase or decrease according to the wiggling of ventilation. The tidal volume here in infant with significant air trapping must be considered to be or aimed to be 2 to 3 ml per kg, and some new ventilator now using like volume guarantee with high frequency. When you have poor lung inflation, less air trapping but more surfactant inactivation and more inflammation, which is the first type described before, at that time the map, you can start by a map which is more than the conventional map by 2, amplitude as a general rule as we said, and tidal volume you can start by 2.5 to 3.5, so little more, and then adjust everything under use of your X-ray and the finding of FiO2 response to that. The third will be congenital diaphragmatic hernia, and I involved also lung hypoplasia because the pathophysiology is relatively similar to each other. So in both cases there is pulmonary hypoplasia, and the pulmonary hypoplasia will have small function residual capacity. There is both atelectasis in an area with some compensatory overexpansion in the other lung or in another area. There is abnormal pulmonary vascular bed developmental in both cases, congenital diaphragmatic hernia and lung hypoplasia, and there is left ventricular dysfunction in congenital diaphragmatic hernia. Pulmonary hypertension is present, which usually or in most cases is not responding to nitric oxide. So for pathological pathophysiology, you have to consider during ventilation of the baby that he has small lung development, area of compensatory overexpansion, there is picture of pulmonary hypertension, hemodynamic, there is left ventricular dysfunction, and plus all of that this baby has pulmonary hypertension. So how we treat? In both cases, we will aim to have gentle ventilation. So gentle ventilation, we are accepting lower blood gas target, the pre-ductal oxygen saturation instead of 90 to 95, make it 85 to 95, especially in case which is severe. We can accept mild hypercapnia, but we will try our best to avoid acidosis. Our ventilation will aim to avoid overexpansion because this lung is not healthy lung, pulmonary hypoplasia, underdeveloped, and the other area which has compensatory overexpansion may get pneumothorax easily. And maintain the hemodynamic stability. Don't forget that you have left ventricular dysfunction. And management of pulmonary hypertension by good oxygenation, and some can try nitric oxide, although it is not effective in most of cases. This is special note about the mean airway pressure for optimal lung inflation. You remember the stepwise increase, then the stepwise decrease to know where the optimal mean airway pressure. It is not recommended here because the mean airway pressure for optimal lung inflation in that case is not the same like that required in normal sized lung, and you can predispose this lung to have leak syndrome. Very easy pneumothorax will occur. So try to avoid this stepwise up and down to know what to determine the optimal mean airway pressure. So as I said, conventional mechanical ventilation preferred than high frequency oscillation here also. This study showing a comparison between conventional mechanical ventilation and high frequency ventilation for congenital diaphragmatic hernia, a randomized clinical trial, leak trial, and it was in 2016 when they compare the effect or the ventilation of babies who are antenatal diagnosed to have congenital diaphragmatic hernia when exposed to or were randomized to high frequency ventilation and conventional mechanical ventilation to see the difference in mortality, the difference in the bronchopulmonary dysplasia, and some secondary outcome. They found no significant difference in the combined outcome of mortality or bronchopulmonary dysplasia between the two ventilation group of high frequency or conventional mechanical ventilation, but they found that shorter ventilation time and less need for ECMO in case of cases which going to conventional mechanical ventilation. And for this case, the congenital diaphragmatic hernia or consortium now recommended conventional mechanical ventilation as the initial ventilator strategy. So conventional mechanical ventilation, what are the mode? We are using the synchronized conventional mechanical mode. Why? Because we are utilizing the patient spontaneous respiratory effort to minimize the ventilator support. The rate, we are using relative rapid rate because we are using short inspiratory time but adequate to make filling without over expansion of the alveoli, especially the compensatory area of hyperexpansion. And because the lung has poor compliance also and relatively small. The PIP, some prefer to stop at the level of 25. When you reach to a level of 25 to give you the tidal volume which you need, which 4 to 6 ml, then better to go to high frequency as a gentle way of ventilation in such case. The PEEP is the same. We are aiming to gentle ventilation, so use of PEEP of 5 and be careful to avoid over expansion of the contralateral lung. Volume guarantee, we are aiming also to use a little less than normal, which is 4 to 5. And if before in part 2 I show you the study which you are using, for example, 6 ml per kg in a normal lung and in a lung which has 25 atelectasis or collapse, and in a lung which have 50% atelectasis or collapse, and how much tidal volume is measured in the area of node collapse, and it's found that it is more in the area which have more atelexes, if you remember this. So more overexpansion of the compliant area of the lung. So reducing tidal volume less than 4 also is not good, because there will be more dead space in relation to the tidal volume. So better to use 4 to 5 and then optimize according to the X-ray. And take care that large tidal volume may cause easy volume trauma. So what is your setting here? So the mean airway pressure, usually you are starting by lower mean airway pressure equal to that which was found in the conventional mechanical ventilation, around 10 to 12, and then adjust up or down according to your X-ray finding. And the frequency here start by frequency of 10 with, if you have your ventilator have IE ratio, better to make it 1 to 2. 1 to 2 for better emptying and avoid over expansion of the area which has compensatory expansion. So lung expansion to the level of 8 to 9 reps by the X-ray is reasonable in that case. The amplitude is the same, just to create gentle wiggling of the mid-abdomen. And we are aiming by the high frequency ventilation for mild permissive hypercapnia and pre-ductal oxygen saturation, as we said, 85 to 95, but try as much as you can to avoid acidosis. The last is the bronchopulmonary dysplasia. This is considered not acute, so it is a heterogeneous combination of a lot of variable airway resistant at different lung region, compliance, which is more affected in the distal part, long time constant, which also is different from area to area, high dead space, variable degree of pulmonary hypertension can present. So it is severely heterogeneous disorder, and by radiological you will find area of hyperinflation alternating with area of haziness or atelexis. So our aim of ventilation here, efficient gas exchange, this is the rule, but reduce the risk of atelexis or more air trapping in this heterogeneous pathology, and lower the pulmonary vascular resistance and treat any associated pulmonary hypertension, and then try to wean off the need for oxygen requirement while gaining weight and nutritional supplementation for the baby. So, in such case, what is the ventilator strategy? For the rate and for the inspiratory time, slow rate and prolonged inspiratory time is needed. And you have to check the waveform for sufficient expiratory time to avoid auto beep and more air trapped. The tidal volume, the dead space in such case, chronic case, is large, and the atelexis is more. So the tidal volume needed must be more, high, up to 6 to 8, and can be increased or decreased according to the age, according to the X-ray, and from case to case. The beep, so important here. A lot of people are afraid from using a beep here, but a beep adjustment of the beep here is very important. It should be relatively high, 6 or more, to optimize the gas exchange, to maintain the functional residual capacity, to avoid regional atelexis, to maintain the alveoli open, especially during expiration, to remove CO2 more. So optimize your beep, optimize your tidal volume is very important in bronchopulmonary dysplasia, plus long inspiratory time to maintain aeration, and you take in your consideration the graphic to avoid low expiratory time and the air trapping and the auto beep and the CO2 retention. So for this you have to have slow rate. So I'm coming from down up, the beep tidal volume, the inspiratory time, expiratory time, and then the slow rate. This is very important. And the unweaning of cases like chronic cases, bronchopulmonary dysplasia is a chronic case. In weaning, it is not like in acute case where rapid weaning and removal of the endotracheal tube is very important. But here the goal of ventilation is to provide stable respiratory support of the baby till reduce the respiratory distress and to improve the exchange, gas exchange till we have lower FiO2 need. And if you can wean the tidal volume before extubation is better, but don't wean a lot, because these babies, as we said, has dead space is more and they need good tidal volume. And also are ventilating till enhance tolerance of care and handling without use of sedation, and provide optimal nutrition for growth for the baby. So when you reach the baby with good blood gas in less than 40% oxygen and saturation is maintained above 90, for example reaching to 92, you can extubate the baby to good support of non-invasive ventilation. And you can extubate the baby from a relative high tidal volume. So you can extubate the baby from a tidal volume of 6. You don't go down to 5 or 4, and the baby will have CO2 retention more, and you will have hypoxia more. So you can extubate from as much lower as you can from tidal volume, but don't go very low like in other cases of acute cases like respiratory distress syndrome. And thank you very much. And this was the third part of mechanical ventilation. The fourth part will come with interpretation of blood gas.